GI pathology, inflammatory bowel diseases. This is your IBDs, your Crohn's disease versus your ulcerative colitis, your UC. All right, this is very high yield. Everything from these two pathologies are going to be questioned, and so we want you to know it fully, okay? The first key takeaway is that IBDs, no matter whether it's Crohn's disease or UC, it's going to be HLA-B27, okay? So it's associated with HLA-B27. All right, we'll talk about more of that in room, but I want you to know that. That's important. Number two, Crohn's disease is Th1 mediated, where UC is Th2 mediated, okay? Now, let's get into Crohn's. So Crohn's disease, it can affect any portion of the GI tract, but it mainly affects the terminal ileum, all right? You're going to see skip lesions and rectal sparing. So what does that mean? So that means that it can affect any portion of the GI tract, but it's usually not going to affect the rectum, all right? That's the first key point about Crohn's disease that you need to know. Number two is that there's skip lesions. What skip lesions mean? That means that it does not always exist as just one whole area of Crohn's, okay? It doesn't exist as not one whole area of pathology, okay? It can be affecting, a portion of the duodenum and then, normal pathology, and then affecting a portion of the colon, okay? So that's known as skip lesions, okay? Those are two very key things that you need to take away, skip lesions and rectal sparing for Crohn's disease. And it can be any portion of the GI tract, both small intestine and large intestine. So next is on kind of grossly, what are you going to see if you were to take the bowel out, if you were to take the whole entire GI tract out? What would you see? You'll see transmural inflammation. Very key, transmural inflammation. So you're going to have thickening of the muscularis mucosa. You're going to see cobblestoning, creeping fat, intestinal wall thickening. Okay, fistulas will form. All right, very, very important to know these. Okay, so fistulas, cobblestoning, creeping fat, intestinal wall thickening. You'll see thickening of the muscularis mucosa. This is a transmural inflammation. I want you to take a look online, look up Crohn's disease gross morphology and look up what cobblestoning looks like and what creeping fat looks like and fistula formations, okay? Because they can show you gross pathology and you're going to have to understand that that's Crohn's disease, okay? Next, what do you see under the microscope, okay? Histologically, you're going to see for Crohn's disease non-caseating granulomas. And that's why it's Th1 mediated, okay? Because you have non-caseating granulomas. Very important to know that for Crohn's disease. Now, what are the complications? Well, you have fistula formation, tons of fistulas, okay? The GI tract becomes sticky, it starts to become inflamed and starts touching other locations, and then the other locations then can become fistulas. So remember, fistula formation is very common. So it can form a fistula with the bladder, and then you're gonna see recurrent UTIs because if you have a fistula between the colon and the bladder, that means that you'll have poop within the bladder. And so then that's going to lead to an increase in infection. So you're going to have continuously recurrent UTIs because normally your urine is usually sterile, okay? So keep that in mind. Recurrent UTIs, that's probably a fistula with Crohn's disease with the bladder. You can also see pneumoturia, okay? So that means that there's air in the bladder. Remember, there shouldn't be air anywhere in your body besides your GI tract, right? So if you form a fistula with anything else, then it's going to have air in that location. So you're going to have air within the bladder. That's another sign of a fistula formation with the bladder, okay? It also causes abscesses and strictures, okay? So very important to know all this. Now, another complication is that you have loss of intestinal absorptive surface area. So you can have absorptive problems with Crohn's disease. Now, usually the patient's going to present with diarrhea that may or may not be bloody. I don't usually look at that as like my end-all be-all. Okay, but it's usually they're going to present with diarrhea. That's usually not bloody, but it could be, okay? Now, extraintestinal manifestations, what happens outside? Well, with Crohn's disease, you have an increased risk of kidney stones. Once again, what's the question? How does that occur? Well, back to our calcium oxalate. What happens is that decreased calcium oxalate excretion in stool leads to calcium binding fat, right? So then oxalate gets reabsorbed, and then it gets excreted in the urine where it can bind calcium in the urine to create stones. So you're going to see increased risk of kidney stones, calcium oxalate stones, and Crohn's disease. You're also positive, okay, patient is also positive for anti-Saccharomyces cerevisitis antibodies. So positive for ASCA, all right? So I just butchered that pronunciation, but you're positive for ASCA. Now, treatment-wise, how do you treat Crohn's? Well, Crohn's, it's an inflammatory disease, right? It's transmural inflammation. So you're going to want to give them glucocorticoids. Okay, so glucocorticoids are going to be very helpful for Crohn's disease. as well as giving them TNF alpha inhibitors. Okay, TNF alpha inhibitors like infliximab or adalimumab, those are TNF alpha inhibitors that can treat Crohn's disease. All right, so remember, overall, Crohn's disease, any portion of the GI tract can be affected, usually not the rectum, okay? It's gonna have skip lesions. You're gonna see thickening of the muscularis mucosa because it's transmural inflammation. You're gonna see cobblestoning, creeping fat, intestinal wall thickening. There's going to be associated non-caseating granulomas on histology, which is Th1 mediated. The complications that you can see are fistula formation, not only with like the bladder, which you'll see recurrent UTIs and air in the bladder, but you can also see fistulas even with the skin near the anus potentially. You can also have loss of intestinal absorptive surface area. You can see strictures, okay? The patients are going to present with potentially increased risk of kidney stones, calcium oxalate kidney stones, and they're positive for ASCA. Treatment would be glucocorticoids and TNF alpha inhibitors. All right. Next is UC. Okay. UC is Th2 mediated, same as Crohn's for HLA-B27. Okay, so they're both HLA-B27. Crohn's is Th1, UC is Th2. Okay. Now, UC ulcerative colitis. Colitis is in the name, so that means that it only affects the colon. It's inflammation of the colon. Whereas remember, Crohn's disease was any portion of the GI tract, not the rectum. Colitis is going to be only in the colon, and it usually always will involve the rectum. Okay, so that's the first key differentiator that you have to take into account. It never involves the small intestines, and it always involves the rectum. Okay? Number two, you're going to see mucosal and submucosal inflammation. Rather than transmural inflammation seen in Crohn's, in UC, you only have mucosal and submucosal inflammation. Okay? And they will say friable mucosa. Okay, friable mucosa with superficial or deep ulcerations is key to ulcerative colitis. You also will see loss of haustra. So on imaging, you can see lead pipe imaging where the colon no longer looks like those like balloons, kind of like they don't look like clumps anymore of separate haustra. They lose that imaging and it just looks like just a straight lead pipe. And that's the lead pipe imaging seen with UC. Okay, or lead pipe appearance seen on imaging. You will see in UC crypt apostases in ulcer formations, okay? But there's no granulomas compared to Crohn's disease, which has non-caseating granulomas. UC has no granulomas, okay? Now, what you also need to know is kind of complications-wise, it could lead to toxic megacolon, okay? Toxic megacolon, so untreated UC with bloody diarrhea. The patient will present with bloody diarrhea most of the time, pretty much all the time. They'll have pain, and they could have sometimes symptoms of shock. And on abdominal x-ray, you could see a megacolon, okay? And that's going to be toxic megacolon. That's one of the complications of UC. It could lead to perforation as well, all right? You will also see an associated MPO-ANCA, P-ANCA positivity, okay? And that is, I cannot tell you how high yield they want you to know that. It is positive for P-ANCA, okay? MPO-ANCA or P-ANCA, all right? Very important to know. And the treatment here is pretty much like mesalamine is pretty much like the main treatment, okay? And then 5-ASA preparation is also another treatment, which is just aspirin that becomes aspirin once broken down by the gut bacteria, okay? But mesalamine is kind of the key one, along with 5-ASA, all right? So this is our differences between UC and Crohn's disease. I would say Crohn's disease is much higher yield to know, but you also they're always gonna compare it to UC. So you have to know the differences here, all right? That's all for inflammatory bowel disease. Please reach out if you have any questions.